Morning. How you doing, everyone? Welcome back. I think I'm on yet. Microphone's on. Good. Talking about this today. Hopefully, you got some good information from all of the knee stuff that we did. If you're dealing with patients or exercise clients, then hopefully that dive into the knee really helped you understand the anatomy and how everything moves. Good morning. Morning, Becky. How are you? Got a few in this morning. That's good. Cool. I've got good morning from Facebook user. I'm not sure who you are, but good morning. Again, if you've not done this before and joined in live, if you click on the eCam link, then we'll be able to see you and your profile. Good morning, Isabella. Happy Monday. And Sarah and Penny. Good morning. We've got the usual crew. Oh, of course, and Julie as well. Welcome, everybody. Cool. So so we did like I said, deep dive into the knee. I don't know whether to even put this on the screen. Brace yourself. Oh man, that is a massage therapist joke, is it that one? And a dad massage therapist joke at that. I'm going to be nicking that one, Tristan. Thank you for that. Cool. Right. So we're going to have a look at the pelvis and the hip. So what we've done so far, obviously, gone into the ankle, gone up the shin, then really focused around the knee. But because the knee is connected to the hip, we've had to do a little bit in the hip as well. So you've been introduced to some things in the hip and the pelvis. But just fleetingly because we were focusing on the knee end. But now we need to go up into the pelvis and the hip. So hopefully you'll see how everything links in together. No, I'm afraid not. Sorry, I don't know who you are, but I apologise. Maybe you have to click on again. I don't know. I agree, Becky. That definitely. Good morning, Fiona. Welcome back. Good to see some familiar faces. We've had a few new joiners over the last couple of weeks, so hopefully you're able to make the live sessions. If you're not, then in the Facebook group, on the photos tab, although it says photos, all the videos are in there as well. And you just scroll to the bottom of the videos and literally it starts on kind of pre-learn anatomy online stuff. So stuff that I taught probably about 5-6 years ago. And I've also put together an introduction to anatomy course as well. So if you're completely brand new and this is your first introduction to it, I realise that even some of the words that I say in this session will be a bit confusing. So I've put together a free anatomy introduction course. I'll put a link in the group and you can sign up to that if you've never done anatomy stuff before. And it will introduce you just to the basic terminology of and we're going to cover some of those today as well. So, and if you want to share that course with anybody, if you think they might benefit from it, then obviously it's free. You can share it away, no problem at all. Blimey, we have got a few in this morning. Okay, so Steve is in. Good morning. Very good. Error press check. Yeah, that's the most important ones. Yeah, good. Good morning, Nicola. Good to see you. Natalie. Okay, cool. Good morning, Natalie. And Rach is in. Good morning, Rach. Good morning. You made it. Well done. Very good. Cool. So let's get going. Let's just click on that one. Here we go. First of all, again, if you've not done these before, we start off with the bones and bony landmarks, and then we build on those. So we'll go into more of the connective tissue next week. So we'll be looking at the ligaments and the bursa around the hip and the pelvis. And remember doing this from last time, and there's a lot more bursa than you think there is or there are. So it's and if you've never heard of bursa, then you'll know what they are. Yeah, Natalie, all good. Yeah, thank you. Good morning. Good to see you back. Okay, so let's get going then. So before we start, there's a few words that we need to clarify. because we're going to cover some of these today, and you might have heard them before and you didn't really know what they meant, or you might have never heard of them before at all. So these, just grab my arrow. There it is. So we're going to be talking about something called ramus, or rami as well, if it's plural. So a ramus is a branch. So if you think about branches off of a tree, then that's a rami or a ramus. A tubercle is a lump, and there are different types of lumps. We've got tubercles and tuberosities, and the other one that's not on there are trochanters. So all the T's are usually lumps. So tuberosities, tubercles, trochanters. We're going to be talking about those today. The fossa is a dip or a shallow in the bone, and usually it's where quite a broad muscle attachment will be. And then a foramen is an opening, usually where something goes through. So definitely we'll be talking about that with the pelvis. We've already mentioned it when we've been looking at the nerves that come down to the knee. So the obturator nerve comes through the obturator foramen. So we're going to have a look at that in a bit more detail. Good. Al, good morning, mate. Good to see you. Cool. We got a right bunch in this morning. Right, let's go on to the first bit. So, yeah, I found this really good program. I don't know how you guys learn, but I love drawing stuff, and I kind of remember things when I draw things or see things visually. So I found this thing on the iPad. I'll pop a link in the group. I think it's called Sketchbook or something like that, and you can put an image as an underlay and then lay another layer on top of it, and then use an iPad pencil to draw around the image. So basically, like tracing. And who doesn't like a bit of tracing and colouring in? And this is one I did earlier, as you can probably tell. So I put an image of a pelvis underneath and then drew in everything, and then you can colour things. So it's a great way to visualise your anatomy and be able to do revision that way if that's what you're here for. So your hip and your pelvis. So this is mainly to do with the pelvis. That obviously this drawing here. Your hip. Let me just grab a femur. So I've got a plastic femur, but a real pelvis. Okay, so yeah, on this pelvis, you can see all the different kind of anomalies on it. We'll show you that in a sec. But obviously, we've got the femur going into the pelvis. That's your hip joint, and that's also called your coxal joint. So COXAL. That's the kind of official name of that joint. So what we've got here is a breakdown of the regions of the pelvis. So this part of the pelvis just here. And again, if you've done anatomy before or done sort of level 3, level 4, level 5 courses, then you probably will have heard of some of these regions. And the top part, so this bit here, well, the whole thing is called the innominate bone. And the innominate means the bone with no name. Which is kind of weird. By giving it a name, surely it has got a name, which is a bit bizarre. But yeah, so we've got this bit here, which is the flat part of the ilium. So all of that part there, or the pelvis, and that is called the ilium. So that's that bit there. So this is why some of these areas or the areas around it are given specific names. So this bit here is the iliac crest, and it's because this bit is the ilium. Okay, so kind of related to the name of the region. Then you've got your ischium, which is this bit down here. And if you're sitting on a hard chair, if you just put your hands underneath your bum and then just sit on your hands, the bony bit you feel, that is your ischium. Okay, and there are some bits of the ischium that are called ischial. Okay, so again, that's where the names come from. And then around the front here, you've got your pubis. So that's your pubic region around the front here. And again, you've no doubt heard about that region. And you've got pubic tubercles, pubic symphysis. And again, we're going to go into those in a bit more detail. So all of those are to do with the pubic region at the front. Okay, we've got some important muscle attachments into here as well. And we've also got some specific injuries that you can get, or conditions that you can get around this region, because you've got a ligament that attaches from here to here, and it's a weak point, especially in men, for herniation. So we'll talk about the different layers of fascia of the abdominal wall, and then how sometimes things can push through that fascia, and you'll get a inguinal hernia, okay, or inguinal hernia, however you want to say it. And then you've got your femur, which is what we've been talking about over the last couple of weeks, but we've been looking at this bit. We're now going to start looking at this bit. Okay, so we're going to be moving up onto the top part of the femur and where it attaches into the pelvis. Okay, so that's where we are at the moment. Just move me out of the way. Okay, so this is kind of traditional look of the pelvis that you'll see in a lot of textbooks. So there's your pubic region at the front, just there. This is your ischium, so that's your sit bones, and then there's your ilium just in there. And those ilia, because they're quite fanned out, that they're often called alar wings. So alar wings. So sometimes you might have seen it called that as well. Even on this image, even though it's fairly clean, they've left in some of the ligaments just here and here. Basically, you can't see the bone on a pelvis. Okay, it is absolutely covered, especially the back and the front of the sacroiliac joints. So the joint between this bone, which is your sacrum, and then these bones, which is the iliac part of the pelvis. So this is your sacroiliac region, so just here, and that is just completely covered with ligaments. Okay, absolutely covered with them. And there's been a lot of debate over the years about the movement in the sacroiliac joints and whether you can palpate it. In the literature, it's there's a broad range of movement that we think is available in the SIJ, in the sacroiliac joints. So these joints in here, and it is between 2 and 18 degrees. That's the rough consensus of how far they think it can move. And then if you think about all the tissue that's on top of that as well, so the tissue around the back, you've got all the gluteal muscles, you've got all the connective tissue around the back as well, and then being able to palpate movements around that region is and do it with any kind of degree of accuracy is very, very difficult. Nigh on impossible with most people, I would suggest. So there's a lot of anatomists, and if you come to the anatomy labs, then you can have a chat with them, see what they think. They're not clinicians, so they see things just from a purely anatomical point of view, and a lot of them will say that thing don't move. We know that it does. There is evidence that it does, but the movement that there is very minimal. Okay, so that's something to think about. Yeah, that is going to be brilliant. So I've followed Diane Lee for about 15 years, and I used to do a lot of Diane Lee stuff, and then I've moved away from that because of looking at the evidence behind things. So it's going to be really interesting their debate, and I'm similar to Anthony, where I kind of sit half and half in both camps. So that is well worth checking out. This is very timely actually for this sort of hip and pelvis anatomy session. So yeah, have a look at Diane Lee and Adam Meekins. That's going to be really good. Cool. Right. Let's go on to the next bit, hopefully. There we go. Okay, so joints around the hip then. So hip and pelvis, there are 3 joints. So we've got the coxal joint, which is what we've just looked at. So that is your socket, that bit there, and then the ball going in the socket. Okay, so that's the coxal joint. Then you've got the sacroiliac joints, and I remember someone saying last time that this looks a bit like an elephant. It's a very the sacrum doesn't move that much usually. Okay, so you've got the sacrum and then the ilium. So this joint in here, this is the sacroiliac joint, and if you have a look at the joint, it's like I said, this is a real one. See if I can put this on the bigger camera in a sec, but you can see the surface of the joints in between. They're very, very irregular. They're very bumpy, and they're kind of it's shaped like an ear. So it's called an auricular joint. So AURICULAR, auricular. So it's shaped like an ear, and that is the movement that is available at that joint. So it's not like a hinge. It's like a C shape. Okay, so it will sweep up and sweep down, and it's given a specific name, which we'll talk about later on. And then you have your pubic symphysis or symphysis pubis, however you want to say it, and that is the joint at the front. So between your two pubic regions, so from one side and the other, there is a cartilaginous joint in between the two. And that's called your pubic symphysis. So this isn't a solid ring. This is made up of things that can move. Okay, and the idea is that it helps to absorb shock from the lower extremity and then create movement in the upper extremity. So if this was a ring, like a bony ring, if you jumped, then you would probably fracture your pelvic. Well, obviously it depends on how high you jump, but you would probably injure the bones because it would be a solid ring. Yeah, so we've got this bit of play, bit of movement in here, so that it adapts to us ambulating. Okay, so moving along. So the sacroiliac joint will move, and you'll get some movement in the pubic symphysis as well. Okay, and you might have heard of pubic symphysis dysfunction, especially in those that are pregnant and those with hypermobility disorders. So something to have a look at, and we'll discuss that when we get into the ligaments. Discuss that in a bit more detail. So this is the pubic region, and you've got your pubic symphysis at the front. So that's the joint at the front there. Your coxal joint, which is the hip, and then the sacroiliac joints at the back. Okay, so let's have a look at these. Make sure I've got the right videos. Yep, let's do that one. Let's get rid of that one. Okay, cool. So these are the bits that we've just seen. So there's your sacrum, there's your coccyx, and we'll obviously cover that when we get to the spinal region. And again, this is a real model. So you can see the irregular shape of the sacroiliac joint. It's not just a straight line, it's a curved structure. And you'll also see that it's not all one size. Okay, so it's not like a block. It's smaller at the back and then wider at the front. Okay, so the sacrum is a lot wider at the front than it is at the back. So that means when we do get movement of that sacrum, we get some flaring of the ilia. Okay, so as that sacrum moves forwards and backwards, then we get these movements as well with the ilia. But again, 2 degrees to 18 degrees. So if you think about that on an old school protractor, and you look at the movements that are available, maximum 18 degrees in ligaments that are normal. Okay, so if you don't have a hypermobility issue, that's going to be really, really difficult to detect with your thumbs. Okay, so some of the tests that you might have heard of, where you do a forward bend test or you do a backward bend test or lift the legs, we may detect some movement, but we can't specifically say that it's coming from that SIJ. It's really difficult to kind of hang your hat on that and say for sure. And even for those where that is an issue, and we do some kind of manual therapy or exercise therapy, because our treatments are so broad and our exercises work on so many different things, we can't be specific with our exercise prescription or our manual therapy prescription. So does it actually matter? Probably not in terms of outcomes, but you've got to be careful what you say to people. So if someone thinks that they're all jammed up and they need clicking back into place, and that's the thought process that they have, then that's an unhelpful kind of message to give to people. So we've got to be careful. We can kind of internalize it and rationalize it however we want. We've just got to be careful what we say. So let's have a look at this. Okay, so these are your innominate bones, so the bones with no name, even though they're called innominate. And then you've got the sacrum. Ooh, move me out of the way. Let me just pop that back there. Okay, so I've got some new words on here. So iliac crest I mentioned earlier before. So a crest is like a raised area. Okay, so we've got crests and lines, and there's a lot of lines on the ilia as well, because around the back, the posterior aspect of the ilia, you have, you might be able to make them out on here. We've got gluteal lines. Okay, so there's a line that's a little bit lower, which is for glute minimus. There's one for glute medius, and then the top line is around that iliac crest, which is glute maximus. So we've got these three different lines where the big gluteal muscles will attach to on the back of the pelvis. Okay, so but they're quite flat, whereas the crest is raised. Okay, so that's why it's called a crest. And then we've got ASIS, which is your anterior, so towards the front, superior, high, iliac spine. So we've got basically a sticky out bit at the end of the iliac crest. And that bit there that's just below it, that's your AIIS. So anterior, inferior iliac spine. And there's certain muscles that attach onto there. I'm just going to try and turn off my notifications a second. They never stop. Here we go. Put me into focus mode. Do not disturb. There we go. Okay. Right then. So yeah, so that's your sacroiliac joint. So between the sacrum and the ilia, there's your pubis at the front and the pubic symphysis. And then this is your ischial area, just down here. And then spinning this around, just move me there. So this is the picture that we saw before. So this top bit here is your ilium. So there's your ASIS from the side, iliac crest. There's your pubis just there. So this region here is the pubic region. Okay, and then this one here is your ischial region just there. Just play that again. So there's your ischium, and then there's your pubis. So it's basically divided through the socket. Okay, so the socket's kind of divided into three. And then we've got these notches. So the notches are kind of carved out bits in the bone, and you can guess what goes through here. So we've got a greater sciatic notch, so this one just here, and then there's a sticky out bit there. So this is called your iliac spine, and then you've got the lesser sciatic notch just there. So we've got ischial spine, sorry, rather than iliac spine. So that's your ischial spine just there, and there is a ligament that attaches onto that ischial spine. That is important when it's dividing certain structures that pass through those notches. So we'll have a look at that when we get to the nerve supply and the blood supply later. This is a foramen. And remember, the foramen was a hole, and then there's your ilia just at the top, or ilium. Either way, that's a correct way of saying it. And then there's your obturator foramen. Let me just pause that right at the end there. Oh, just missed it again. Well, you get the idea. So it's just there, okay? And when we were doing the nerves that go down to the knee and supply the muscles that affect the knee, we looked at the obturator nerve, which is down the inside of the leg, and it goes through that obturator foramen. And there are some other muscles as well. So there's a very thin sheet of connective tissue that fills that hole. So it's not just a hole, there's like a membrane that goes across it, and then the muscles attach onto the front and the back of that membrane, and they then attach onto the femur to bring about rotational movement. So we'll have a look at that when we get to the muscles. There's loads and loads of muscles all around this region. Okay, loads of them, and we'll talk about that when we get there. Cool. Right, let's go back to this. So that's basically what you've just been looking at for real. Let's move on to the next bit. Here we go. Yeah, so pelvis made up of the ilium, the ischium, and the pubis, so what you've just seen. And the main functions, that transference of weight from the vertebra to the legs. And there's a really nice book. This is a really old book by a guy called Grakovetsky, Serge Grakovetsky. and he talks about something called the spinal engine, and the fact that the rotation in the spine helps to whip the legs through when you walk. And that if you have a look for the spinal engine on YouTube, I'm sure there are some videos with Serge Grakovetsky talking about the spinal engine. I went to see him when he came to London about 10 years ago. I'm not sure whether he's alive still. I hope he is, because he was a genius. Yeah, if you have a look for him, let me just type his name up because it's a bit of a weird one. Think that's how you spell it. So Grakovetsky. Okay, spinal engine. If you have a look for that, then you'll get that information. And then it's an attachment site for muscles, and there's loads of muscles that attach onto the all the regions of the pelvis, and then withstanding compressive forces. So it's like impacts of hitting the ground. Everything kind of absorbs that impact, and then it uncoils to produce movement in whichever direction you want to go. Okay, so it can't be rigid. It has to be able to move. Okay, right then. So these are all the bony landmarks around the pelvis, and we're going to have a look at some of these on the cadaver model in a second. Let me just get rid of that ticker. There we go. Okay, so if we start at the top, so we've already had a look at this. So this is your iliac anterior superior iliac spine, and then there was the inferior one as well. So we talked about that earlier, and we've got the reason why we've got these bony lumps and bits that stick out is because muscles attach onto those points. Okay, so as you develop, as the muscles pull, I've said this a few times, so apologies if you've heard it before. As the muscles pull on the tendon then pulls on the bone, and then the bone starts to pull away a bit. So you create a bit of a gap, and then the gap is then filled in. It stimulates osteoblast cells, and those cells build bone. So as they're being pulled away and then stimulated, it fills in that area with bone. So that's why we get these bony lumps. So your ASIS is at the front, your AIIS, which you can't really feel very well because it's quite deep. But your iliac crest line as well, that's there's loads of muscle attachments on there, and that's why it's a ridge rather than just flat. The pubic tubercle, your abdominal muscles attach onto there. Okay, so you've got the pubis here. Remember what we said ramus was, so that's a branch. So we've got a ramus of the ischium, okay, just here. Your ischial tuberosity, so remember tuberosity was a lump, okay. Oh, blimey, I've just seen that. So spinal engine was on Amazon for like 20 quid during lockdown, but just looked and it's available for not available for less than 480 quid. Can have my copy for 200. Okay, deal. I'll see if I can find it cheaper and find you a link. Ischial tuberosity, just there, so that's your sit bones, and then this here, so the socket of your ilium, pelvis, is your acetabulum. Okay, and the acetabulum means vinegar cup. Okay, and it's from Latin, because the acetabulum looks like the shape of an old vinegar cup. Okay, and when the femur fits into that hole in there, it is surrounded by some fibrous tissue that creates like a suction into the joint. And I've got a really cool video that I'll show you when we do the that region and all the connective tissue, where somebody is trying to pull the femur out of a cadaver. So it's a really cool video. It's something that I like, but it's really tough to pull out, really tough. And then when it does, it goes. There's a really big pop sound because of the negative pressure holding the femur in place. Okay, so the structure of it and the design of it is designed so that it can keep that, and it needs to be really strong because obviously all your body weight is going for it. Very different to the shoulder. So the hip socket, ball and socket, obviously there's ball and socket in your shoulder as well. The socket in the shoulder is like that. Okay, so it's really flat with the ball that can roll all the way over it. So we've got loads of mobility in the shoulder. In the hip, there's much less mobility, but the strength is greater. Okay, so the shoulder sacrifices strength for mobility, and it's the opposite way around in the hip. Okay, here's the inferior gluteal line. So that's where your glute minimus will attach, and then you've got an anterior gluteal line just around there. So that's where your glute medius attaches onto, just there. And this is really important when you're palpating areas in the pelvis and the hip to see where something is tender. Okay, so if you're if it's up around this region here, so there's the posterior gluteal line just there, and then it follows up on the iliac crest. So that bit there is all where your glute maximus will attach onto. And usually if you've got gluteal problems, it hurts around the attachment points. So around here, around there, or around there, okay? And if you come to do things like shockwave therapy, especially focus shockwave, you have to have this in your mind because this is where you want to aim your treatment. Okay, so it's important to know where the attachment of those muscles. This bit at the back, PSIS, that's your posterior superior iliac spine just there. Okay, we do cover this in a few weeks' time, but there's loads of variation in the pelvis. Okay, so you can have ASISs that are completely different sizes from one side of the pelvis to the other. So from left to right on the same person, this can be an inch, and then on the other person it might be 2 inches. On the other side it might be 2 inches. So if you're trying to use those landmarks to ascertain whether someone has a tilted pelvis, you won't have a clue because sometimes the bony landmarks are different. So if anybody has ever done those checks on you and they've said, oh yeah, you've got a rotated pelvis this way or that way, and I hold my hands up, I used to do those checks, and I now know that there are so many variations that you won't be able to tell whether the pelvis is rotated or they've just got a longer ASIS on one side. Same with this. So the iliac crest here, there can be differences in the height of the iliac crest, sometimes by a couple of centimeters. So if you put your hands on someone's iliac crest to ascertain whether one side is higher than the other, it might be that they've just got one iliac crest that is bigger than the other side. So it looks as if it's tilted, but it isn't. Okay, and we won't know unless they have an X-ray. Okay, so and then you're not going to send everybody for an X-ray just to check that. So all of the tests that we do around this region, if we use bony landmarks, the reliability of them is really poor. Okay. It's a good question. Is it likely due to the stress placed on the area and osteoblasts laying down? There will be an element of that, yes, definitely. So different people's activity levels will mean that they'll have different structures of the bone, but often it's just genetics. So they've blamed their parents for it. So some of it can be developmental, but a lot of it is congenital. So they were just born that way. Okay, and it's very, very common. It's more common than not, to be honest. Okay, cool. So we've looked at some of these as well. Just going to briefly go over these, and then we'll have a look at the videos again. So iliac crest, this region here, there's the auricular shape of the sacroiliac joint. So it looks like an ear, so a kind of C shape. Iliac fossa. So remember that was a dip or a hollow. There is a huge muscle that attaches on there. Really, really powerful, strong muscle. Superior, above, ramus, branch of the pubis. Okay, so that pubic region at the front. So we've got this branch of the pubis here, and then an inferior below, ramus, branch of the pubis just here. And then there's your obturator foramen again. Okay, let's have a look at some of those. Let's get onto those. Yeah, this one. Just get rid of that one and that one. Okay, here we go. So similar to what we saw before. So there's your acetabulum, and there's a vinegar cup. Just scroll back through there. Well, Do not disturb thing didn't work, did it? Okay, acetabulum just there. So that's your socket of the ball and socket joint, obturator foramen, and there's your pubis. So this is the articular surface, so the joining surface of the acetabulum. So that's where your head of your femur will attach into that point. Obturator foramen, so obturator hole. There's the body of the pubis, superior ramus, so the ramus is a branch, and then inferior ramus, and then pubic tubercle at the front. And you can palpate those pubic tubercles. You just hands on the belly and then just push down. And quite often, especially with manual therapists, they'll often avoid that region because they're told in their training you don't want to be poking and prodding anybody there. It's actually really important for groin issues because that's where a lot of the adductor muscles will attach and where your abdominal muscles attach as well. And it's also a region where they may have a herniation. So it's important to learn the skills of actually how to palpate that region rather than just avoiding it altogether. And it's very, very simple to do. You just make sure that you keep your hands really flat. They cover their bits, so you can't go anywhere near where you shouldn't be. And then you then just palpate down towards those pubic tubercles, and you can feel the pubic tubercles to see whether they are tender. Okay, and if there is some tenderness there, or you feel some kind of irregularities in that region, then they might need to be sent away for a scan. So it's important to be confident in checking those areas. So yeah, and if you know your anatomy, then you'll be fine. You won't be anywhere near anything you shouldn't be if you are at that level there. Okay, anything below that, you're going to be in trouble. But there, no problem at all. Okay, it's just how you go about doing it. Okay, so let's have a look. We've covered all those. Okay, so this is a view from the back. And then here we're starting to bring in some of the ligaments as well. So we'll talk about a bit more about these in the coming weeks. So we've got an iliac fossa at the back, and you can see the gluteal lines there as well. Iliac crest. Okay, so we've had a look at that before. Ischial tuberosities, or your bum bones, and then the ramus of the ischium just there. And there's your PSIS. Okay, so that's the bit at the back as well as at the front, the ASIS, but the PSIS can be different sizes from side to side. So it may look as if one side's higher than the other, but it might just be that they've got a bigger PSIS on one side than the other. Okay, so we've got, again, the reliability of those tests is you've got to question the reliability. And if the reliability is poor, then the validity of your tests is going to be poor. So what you think you're testing for, you might not be testing for. These ligaments here, really, really strong structures linking your ischial tuberosities up into the sacrum. So we've got these, and like I said before, you can't really see this region in a cadaver. It's just covered in ligaments. Okay, absolutely covered. So again, when we get to that, we'll have a look at that. Cool. Right, let's just make sure that I've covered all these. Just show you the last video on the pelvis. Yeah, it's this one. I think we've done that one. Yes, this one. Sorry. Okay, cool. So I think. Oh no, we did look at that one. Cool. Yeah, we've covered all those. Brilliant. So we're going to have a look at the femur. Just get rid of those, bring up that one. Okay, cool. So we've been focusing down here over the last few weeks. We've been looking at the knee joint. We're now going to be having a look more closely at this region here. So we need to see how it all kind of fits in and learn the names because they're going to be important for learning the muscles later on and the ligaments. So there's your ASIS, there's your pubis. This is your head of your femur. And then there's the neck. These lumpy bits here are your trochanter. That's your greater trochanter just there. And you can see the range of motion that the femur has got. It's pretty good because of the design of it, but it is limited. It's not anywhere near the movement you've got in your shoulder. So that's your greater trochanter just there. And then there's your lesser trochanter just there. I'm just going to pause that a second. So your greater trochanter is really important because this is often an area where people get pain. Okay, so you need to be able to poke and prod around that greater trochanter to, but you won't know what is the tissue that is irritated. When we come into attaching the muscles into here and all of the bursa that are around this region, there's loads of stuff attached onto this greater trochanter, loads of it. So we used to call some of the issues with the back of the hip piriformis syndrome. We now call it a greater trochanteric pain syndrome because we don't know what's causing the pain. Because there are so many structures there, it could be any of them. Okay, so we can't be really specific, especially with the kind of tests that are available to us as sports therapists, manual therapists, whatever it is you do. So yeah, we can't say, oh, you have piriformis syndrome. It's you have some kind of deep gluteal issue. Okay, so yeah, again, we can't be that specific, and it's not a problem because our treatment doesn't really change, but it's just what we tell people has to change. So there's your lesser trochanter just there, and there's another key muscle that attaches onto that later on. Cool. Yes, Stevie, I remember this actually. Yeah, I said before, Noah Ladd born without a sacrum. Imagine how his anatomy is in that region. Yeah, must just be full of full of ligamentous tissue. Yeah, amazing. I guess that's linking in with Stevie's. I've never heard of it, so yeah, that'll be interesting. Sacral agenesis. So I'm guessing he's had it from birth. Well, he must have had it from birth unless he had an accident. So yeah, it just didn't develop. Yeah, interesting. So there's lots of things like that. I mean, my area was the shoulder, so I've looked at things like Poland syndrome, where you don't develop a pec. Yeah, and it's just that sequencing just doesn't happen for whatever reason. We don't really understand fully why. But yeah, if certain piece of embryology is not activated, then the area just doesn't develop. Okay, so that's sounds like that's what's happened to that chap. So we've got a greater trochanter, and then we've got a trochanteric line. So intertrochanteric, in between the trochanters, and then round the back, there's an intertrochanteric crest. Okay, so the crest is raised. So like I was saying before, the iliac crest, and the line is flat. And then this one here, this is really important. Just pause that there. So your glutes, your glute max attaches into there. So it goes quite far down your femur. So when people come in and they do complain of kind of hip issues, have a bit of a feel along there. So you feel from the greater trochanter and then kind of lateral posterior, so that kind of region, and it's quite close to the surface, and you can give that a good push in there. And quite often that is a real source of discomfort, and that can be part of a gluteal tendinopathy. Okay, so because we've talked about the other end near the ilium, but where the glutes attach down here as well, that can be a real issue. So you can see all the bobbliness of that muscle there, and the glute then attaches into your IT band, which we had a look at when we were looking at the knee. Okay, so there's some other structures down here as well. So all that bit there, that is your linea aspera, or linea aspera, however you want to say it. And on that linea aspera attaches all of these muscles. So basically linea aspera means white line. So it's not a crest because it's not raised. It's a line on the back of the femur. And these are all the muscles that attach onto it. And we've had a look at these in the previous video. Okay, so vastus medialis, longus brevis magnus, short head of biceps, and your vastus lateralis all attach onto that linea aspera. So really broad attachment points on the back of the femur. Oh, cool. Robert's pelvis, a pelvis that is narrowed transversely due to the almost entire absence of the ala of the sacrum. Interesting. Cool. Thank you. Perfect. Every day is a school day. Yeah, pop a link for that in the group if you can. That would be really good. Cool. Okay, let's just have a look at this. So just going over those points again, we will cover these. These are the ligaments that form the capsule of the hip. There's your greater trochanter just there. And that one you can feel on the outside of your hip, the shaft of the femur, and then lesser trochanter just there. So you've got some really powerful hip flexor muscles that attach into that point just there. Guess what muscle attaches onto that bit? Okay, so this is your pectineal line. Remember, we were talking about pectineus in the when we were looking at the things that affect the knee, and we were going around the inside of the thigh and the adductor muscles. Okay, so we'll cover those in a bit more detail up this end because this is where pectineus attaches. The neck of the femur, intertrochanteric crest. So the crest is round the back and the line is at the front. Okay, and then your gluteal tuberosity, which is that raised line where your glute max attaches. Okay, so we talked about this before already. So very stable joint. It's got a close fitting femoral head on the acetabulum. So it's not like the shoulder joint where there's loads of movement. It sacrifices the movement for stability. The position of them within the body, there are loads of muscles around this hip. It will be solid. Okay, absolutely solid. There's a load of structures around here, and then also the strength of the surrounding ligaments. So the iliofemoral ligament, and now you know the names of the regions of the pelvis. Hopefully you'll know where this one goes. So from the ilium to the femur, okay, that is the strongest ligament in the body. Absolutely solid. Okay, so all the ligaments, the muscles, plus the shape of the joint all make that hip really, really tough. Okay, cool. Done. Okay, so if you've never done the hip and pelvis before, have a look over this video again. Get yourself used to the regions of the hip and the pelvis because next week when we add the connective tissue on, it will really help you work out where things go from and to, because a lot of the ligaments are named after the bones, all right, and the regions of the bone, bony landmarks, that kind of thing. Okay, so have a good week. I will see you next Monday, 10 o'clock, and I think it's the 31st of January. January is nearly over. Crazy. Okay, so we'll see you next week. Take care.